Good afternoon, everybody. Thank you for being here for the fourth in our series of My Story. We have had just such a remarkable time with hearing about people's individual stories about their interactions with the safety net, with the health and human service community in Lincoln, and it's come straight from the voices of people who've experienced it themselves and people who very closely associated with people who've experienced it themselves. And that's why it's been so remarkable. We've been inspired, we've been touched, we've been motivated by all of those stories, and I know it will not be any different today. So we've been encouraged to continue having these series, and we're thinking about doing that. If you really have any ideas about great topics for the My Story series, we would encourage you to let us know. We would be happy to work with you or your agency or you personally to do that. So please talk to Marcia and I, and we will happy to have that conversation with you. So on to today's program. It's about cancer. My cancer has impacted my family. My guess is that it's probably impacted everyone in the room. My mom was a two-time breast cancer survivor, underwent some really pretty ruthless cancer treatments when I was younger, and survived to tell her story. But I know that it affects and impacts people in a very deep and profound way. And I think certainly for people who are from ethnic and racial minority populations, people who are experiencing low income a situation, it's even tougher. If you look at the data, Marcia gave me some here that I know well, and that is that the death rate for all cancer combined is 25% higher among African Americans than for whites. That in itself should encourage us to do something. And of all racial groups, white women have the highest incident rate for breast cancer, but African American women are more likely to die from the disease. So these disparities are continuing, and that's what we want to talk about today, about the impact that cancer has on people here in Lincoln and what we're doing about that. So we're fortunate to have three people today who are going to tell their story, and I'm going to introduce them to you briefly. The first one is Dr. Derrick Anderson on the far right. Derrick has practiced medicine here in Lincoln. He may, someday return to Lincoln. No pressure, Dr. Anderson, but currently he's practicing family medicine at CHI Allegiant Creighton Health in Omaha. He received his undergraduate degree from North Carolina, but his MD from South Carolina, so he switched allegiances there. He completed a residency in family practice at the University of Missouri, and then he practiced in Papillion and Lincoln before he moved to Omaha. His vision for his practice is to care for patients of all ages, but especially for the minority population, which he feels has been underserved through the years. So thank you for making the drive down to see us. Tracy Rollins was born in Nebraska, raised in Texas, and then returned back to UNL to earn her bachelor's and master's degree in physiology and nutrition. She also worked at the Lincoln-Lancaster County Health Department, where I met her for the first time. She's was a community health educator there, and was also an educator in the Every Woman Matters program, which some of you may be familiar with. While all of that was going on, she was also serving in the U.S. Army Reserves and continues to do so as an officer with over 27 years of experience and service. So we thank you for that, certainly. In September 2012, at the age of 43, she was diagnosed with breast cancer, and she's here to share her story with us. And Larry Williams, a familiar face, I'm sure, to many of you, the son of the late Reverend J.W. Williams and S.E.B. Williams. He earned his bachelor's degree, and I didn't know this. I always learn something when I read these. I think I know these folks pretty well, but he earned his bachelor's degree from the University of Wisconsin, my alma mater. I didn't know we were Badgers. Yeah. And a law degree from the University of Nebraska College of Law. He's worked for the State of Nebraska Department of Economic Development, director of the City of Lincoln Commission on Human Rights, and presently, as many of you I'm sure know, he's the executive director of the Malone Center. He was diagnosed with prostate cancer in October of 2012, and he spent his Christmas Eve in a surgery suite that year. So he is also here to moderate our panel, but also to tell his story. So please join me in welcoming all of these folks here.
Thanks so much, Lori, and thanks to everyone who's here today. We greatly appreciate your attendance. And we have to thank, I think, the Community Health Endowment for for doing this. This has been a great series. I haven't been able to make all of them, but the ones that I've been able to make, I think they've been well received, and I think they've been very, very helpful. And there's nothing more important than listening to people tell their stories, and their stories not only of the pain, but also the stories of recovery. That's the most important thing. And I think probably if we had a show of hands, how many people have had their lives affected by cancer, whether themselves personally, through their family, through relatives, through friends? How many folks? I don't see not one hand that didn't go up. You know, the statistics are that 40% of the people that we know will somehow be diagnosed with some form of cancer throughout their lifetime. So it is a problem, and it is a disease that has impacted us all. What we're going to do today, Tracy and I are going to tell our stories. Tracy will go first, and then I'll go second, then Dr. Anderson will have some comments on healthcare and some of the things that are, part of the whole health system and what we need to think about when it comes to cancer treatment. Again, let me thank you for coming. Thank you for your concern. And I'm going to turn it over to Tracy, and she's going to talk about her experiences.
Good afternoon. My story was not an adventure that I would have ever expected. As an educator in breast cancer, as an avid athlete, although I did know there's a possibility, as breast cancer is not biased toward anyone, I honestly never thought I'd be going down this journey. Got a call from the VA, ladies, the deal, it's that time of the year. Okay, let's go do it. They saw something a little shady, and it's like, okay, want you to stick around. All right, fine, not a big deal. Did another screen, and they're like, well, we're going to take this in, and we'll give you a call. Okay. So, September 12th, 2012, I get that call. We would like for you to come into the office. Oh, no. We know what that means, right? So, that's okay. You can tell me over the phone. Well, no, we really would like you to come in. Please, just tell me over the phone. Really not a big deal. I've just spent 20-some years in the medical. I'm not concerned. Just tell me what it is. So they, of course, tell me, you have breast cancer. It came out malignant. We need you to meet with the surgeon and proceed. Okay, well, if that didn't open up a new door for me, immediately I was at work. So I tell my bosses, I call my mom, here's the deal. And so she goes, oh my gosh, and gets emotional. And the first thing that came out of my mouth then from there was, stop. There will be no crying. There will be no negative emotions of any sort. We will go in, we will fight, and we will conquer. So she's like, well, that's the attitude. I'm thinking, it is the only attitude, Mom. So, so I tell her, whatever you do, don't tell Grandma. Because, Grandma will go nuts. Well, Grandma calls. She goes a little nuts. And it's like, Grandma, I know Mom talked to you, please. No crying, no emotion. We're going to go in, we're going to fight it, we're going to conquer it, we're going to drive on. So we do. We have a surgery for invasive ductal carcinoma, well differentiated, grade 1 of 3. Basically low end, pretty good. Considering that I knew a lump was there months prior. I somewhat self-diagnosed myself. As one of my other grandmas says, perhaps you were too well educated. Well, perhaps I was. And lucky enough, we still caught it, though, in time. And so went in, did a partial lumpectomy. All went very well. 8 weeks off before I did chemo, and did 4 treatments of chemo. 3 weeks apart, so about 3 months total. And then I started 36 treatments of radiation. So somewhat of a long process if you think about it. Basically, the 1st of October until April. So that was, 5-6 months of going through all of that. Did very well. It's amazing, the technology. I was expecting to be sick, on a daily basis. I think I was sick twice through the whole process. And no, I was not taking my medication for that. So that just tells you how well, we've gone with medicine and the technology. The only thing perhaps, white blood cell count, that was an issue. I did have to take some additional shots to keep that up. And but I really need to thank everyone, my loved ones, my job, both on the civilian side and on the military side. They did work with me, and I worked from home throughout this whole process. So I still worked every day. There was an occasional time or two where the boss could actually tell, and she'd say, okay, you're done for the day. Well, no, I'm not done. You're done for the day. So I definitely have a lot of gratitude, and I thank those supervisors that I have, because I would just continue to drive on, no matter how tired I was. So that is my story. 2 years later, as we know, mammograms show there's nothing, and I hope that is valid. I hope it's true. So just with breast cancer, any type of condition, keep a positive attitude, because that's what's going to help you throughout the process.
Thanks, Tracy.
You're welcome.
My story is a little bit different. It's a little bit different. I had no clue. I felt fine. I actually, the only reason I knew something was wrong is that I went to have my physical. And quite frankly, I wasn't going to go get a physical that year, because I think many of you probably know that I'm the caregiver for my sister, who's a special needs adult. And it's just a pain to get an appointment for her, get an appointment for me, you gotta get the lab work for me, get the lab work for her. It's like 3 or 4 trips just to get stuff done. And so she's my primary responsibility, so we're gonna do that and just forget about it. But luckily I was able to get back-to-back lab work, back-to-back appointments. Thank you. Because otherwise I was going to skip it. I felt like I was probably the best shape that I'd ever been in my entire life. I was working out every day. I didn't have any pains. I felt fine. I was running. I was going to the gym. I was doing all those things that were just fine. I did the blood work. Everything seemed to be fine. I was a little high on the cholesterol, a little high on diabetes type thing, close, borderline, but everything else was fine. And then the doctor came and talked to me about my PSA count, and I kind of knew what that was, but he said that it had shot up. It wasn't in the danger zone yet, but it had just increased tremendously. And he strongly suggested that we look at it. And I thought, well, do we really need to? It's just right below the danger zone. It's, and that still was low. We kind of talked about my medical history and my family history. And, I don't mind admitting that I'm an adopted child, so I really don't know what my medical history is all about. I have no idea, I take that back. I have some idea who my parents are now, or who they were. But medically, I didn't know anything, but I did know, first, I'm African American, I'm at higher risk, I'm over 50. And so he said, let's just go to the urologist and have a biopsy. I wasn't really wanting to do this, but I thought, let's just make sure. So off we went to the urologist, and that was not a fun procedure, but, We got through it. I'm not going to go into the details, but it wasn't a very fun procedure at all. It stung and it hurt, and it was just uncomfortable, period. Within 3 days, I got the call. And again, I didn't know a lot about the prostate, but I had some notion about what it does, where it's at, and all that kind of stuff. And he said 30% of my prostate was already cancerous, which just came as a total shock. 30% of my prostate was already cancerous. They weren't sure if it had spread. Surgery was the only option. Well, I shouldn't say there were some other options, but surgery was probably one of the options that I need to consider. I can go back and think about that conversation, but the minute that he said 30% was cancerous, my heart sunk. I never thought this would happen to me. I always felt horrible for other people who had to struggle against or battle against cancer. But I thought this was something that would not affect me ever, but it did. And to say that I was depressed is not even close to where I was at mentally, physically, emotionally, spiritually. My father had died of colon rectal cancer, and I'd seen what happened there. And that was back in 1989. It's been 25 years, which is hard for me to believe. So I knew, what could potentially happen. Things have gotten better since 1989, but still cancer is cancer, okay? And I think another thing that was, I'm not married. I don't have a partner or a girlfriend or anything like that at all. It's just me and my sister. And I felt emotionally helpless. I just didn't know where to go. I would talk to my sister about it, and, bless her heart, yes, we did pray, which is what we do in our family, but I needed a little bit more than that. Once that procedure was done in October, it wasn't until December, after kind of evaluating all the different options that I had, there was a possibility of putting in some sort of radioactive seeds in the prostate to help kill the cancer, or to kill the cancer. That was one procedure. You could freeze the prostate. That was another possibility. The one that seemed the best for me was to have surgery, and that's what I elected to do. But I decided to do the surgery that was not nearly so invasive, but it's called the Da Vinci method. And it's sort of like having your knee scoped. Basically, you don't have large incisions. You have small little incisions here, and one larger incision above your belly button. And that's the surgery that I elected to do. When given the dates that I could have this done, and remember that, quite frankly, October, it's right around this time that I received that call back in 2012. So, and again, I don't believe in coincidences. I believe these are things that are meant to be. I really do. Once I made a decision what type of surgery I did, Googling, got books and pamphlets from the doctor. I made the decision to go with the Da Vinci method. And I had 2 dates that I could have the surgery on. December 24th, 2012, or January 25th, 2013. Okay, so I obviously went with December 24th, 2012, and I went and had had the surgery done then. I feel very, very blessed in the sense that after the surgery was completed, the surgeon came in and talked to me and said that we were able to remove the prostate without any problems. We looked around and we saw one lymph node that looked really suspicious. It had 1% cancer in it. They removed that. It hadn't spread anywhere else. I had a CAT scan and also a bone density test, and it looked fine there. Based upon that result, I did not have to do any radiation treatment or any chemotherapy. And but every 6 months I need to have my blood tested, and I need to. He put me on hormone therapy, And basically what hormone therapy does is it suppresses any cancer cells that might be floating around in your system to keep them from what I would say germinating. And I'm not a physician, but that's the best way that I can explain it. Now, I joke about this, but these are just not regular hormones. These are female hormones. So I always say to women who are going through menopause, I feel your pain. So if you see me taking out a hanky, or I start fatty, and you're just wondering what is wrong with Larry Williams, it is because that's one of the side effects of having hormone therapy. I feel very blessed, okay? If that's what I have to endure for the rest of my life to make sure that cancer does not come back, then that's just what I have to do. That's what I have to do. But I feel your pain, women. I feel your pain on this one. It is very uncomfortable, and you don't sleep that well sometimes, quite frankly. You really don't. I feel very blessed that I was able to get it in time. I feel very blessed that I had a surgeon who I thought, who I know cares about me and really guided me through this. I feel very blessed that I had insurance, okay? Now, I'll be honest with you, I was there basically 2.5 days. And, my total bill was well into the $40,000 range, of which I had to pay a nice chunk, quite frankly, because my insurance wasn't all that great, which is insurance that I had personally myself, that I had kept. I had to use quite frankly, some of my retirement in order to pay off pretty close to a $19,000 insurance bill. So I just think about the folks that don't have insurance, quite frankly. I think about that. What do they do? The shots that I receive every 6 months, these are expensive shots, incredibly expensive. They're basically $4,500 a shot. I get one in the stomach, I get one in the hiney. And that's incredible that there would be 2 shots that would cost that much, and that's what I need in order to stay healthy. So when I think about people who don't have insurance, I just don't know. I don't know. I joke about this. I came away with basically a $50,000 bill, and I did not get one solid meal when I was in the hospital. Not one solid meal. I could go home and fix broth and jello. Okay, and have Diet Pepsi or Diet Coke or whatever. But I am very thankful that I'm here. The shadow of cancer will always be over me. I understand that. It's always there, but I don't let it control or rule my daily existence. And I think that can be said about anyone who's gone through this. But it's always there. It's always in the back of your mind. And then you feel a great empathy and understanding for those who have gone before you and those who will be in front of us that are going to have to deal with this. You just feel for them. I have a very good friend right now who is going through colon cancer, and he's in stage 3. And he has just had a difficult time with both chemotherapy and radiation therapy. And he's done for now, so we're waiting to see what the results have been of the round of chemo and radiation. But it was a struggle. And, the texts, the tears were flowing back and forth. You just didn't think this would happen to us, but it did. And I conclude with this. A lot of folks are saying, why are you talking about all this stuff? Why are you doing this? Because I want men to know, and I want people to know that if it wasn't for my physical, I don't know if I'd be here today. Or, I could easily say, I think I wouldn't be in the shape that I'm in right now. I really don't. Because it was clear that it was spreading. It had gone to one lymph node there, and they got that one out of there. But, it was pretty clear it was growing and was ready to make life really, really difficult for me. So the reason I've done programs and I've talked about this, and it was on my Facebook page and in my emails or whatever, if you've got a man in your life whether he's your husband, your uncle, your cousin, your partner, your lover, whatever. It is imperative that you get checked out and you pay attention to your PSA count. I'm not going to say that's the perfect way to keep track of it. There's a lot of controversy over the PSA. But definitely by the time that I had a biopsy, it was pretty clear. Things were not good. Okay. So that's why I take this public stance. Many say, you need to keep this quiet. That's a personal thing. You're dealing with your malehood. No, I'm dealing with my life. And this is a life issue. It's a life issue. So if you've got a man in your life, make sure that person is paying attention to PSA. And make sure, guys, that you're getting your physicals. I know, they're a pain in the butt. Literally sometimes. But it's important that you do that. It's important that you do that because I had no idea there was anything wrong. And when I asked the doctor, how would I have known if anything was wrong? He said, by the time you would have noticed, it would have been too late. And that stuck in my mind. So if you have a man who's important in your life and you love, be sure they take the necessary precautions because preventative measures are so essential. Thank you for listening to my story. Dr. Anderson.
All right, so I was sitting here trying to figure out how a doctor is going to, take part in this conversation about cancer. And so the good thing and bad thing about being a doctor is I get it from several different avenues and several different directions. So I have the guys that walk in that I'd never met before, and I've had to tell them, your chest x-ray shows cancer. I've had to do that in my office. And they disappear, go on to treatments, and I don't hear from them. I've had to see patients that I've come to build relationships with, inside and outside the office, and they're doing their screenings. We go through the process, and I've had to tell them, you've got prostate cancer. And this one particular guy, he was a big, strapping, healthy guy, brother and everything, and he really didn't want me to do his prostate exam. Well, I convinced him, we did it, and 2 days later, he had his prostate taken out for cancer. So I've had to go through that. I've had to go through, my best friend now is on her second type of cancer. She had lymphoma before and now has a terminal cancer. So I've had to go through that on a personal level because as soon as she told me, I knew the scenario wasn't good and her outlook wasn't very good. So I've had to go through that on a personal level. What's the best case scenario? The best case scenario is actually the guy that I've convinced, I got to screen, I got to check you. I don't want to do it, I got to check you. And we check in and then we find something early so that we can take care of it early. The worst case scenario is the guys that come in and I've seen them, I've tried to talk them into getting these tests done. And like you said, maybe the PSA is not the best, but it's the best thing that we have right now. And so if I can't convince them to do the basic screenings, then they come back and we do it and he has cancer. That's probably the worst case scenario because I've tried to convince them that this is something good to do. And so what I ask my patients that have, gone on and survived cancer is that you have to tell your story. You have to make your personal story public a little bit because I only see the guys when they've been convinced to come in. And so it's not uncommon for a wife to come with a husband and he's only there because she made him come in. So I need some other people out in the community to say, hey, I did my test and yeah, it's uncomfortable, it's awkward. But after you get it done and it's negative, then you'll feel fine. Mine wasn't, maybe the guy would say mine wasn't and I had to go get treated. And so that's his motivation for getting his friends, his family into the clinic so we can screen for some of these things. Because the reality is the later you find any of these cancers, the worst case the scenario. We've done pretty well with Every Woman Matters. And so we'll get women in and honestly not all the providers are willing to go through the packet and do the questions and do the labs and send the packets in. But I probably hand that packet out at least once a week. And so we hand them out because women will say, I don't want to do the pap smear. I don't have insurance for the pap smear. I don't have, I'm not going to do a breast exam. And I give them the information. I say, we can at least cover you for those things, and we'll deal with whatever we find. We don't have the same thing for guys. And so what typically happens is the scenario of they come in and it's pretty much too late. That's usually the guy presentation. The female presentation is, we're finding things fairly early. Oh, it's a nodule, it's benign. There's many more of those scenarios in my clinic than a woman coming in and it's too late. If she doesn't have insurance, of course, that increases that rate, right? Because they're not getting the screening test. And, we've actually, manipulated the screening time frames a little bit. So we're not doing pap smears every year. When I started, we were drilled, they got to come in every year. Well, you don't have to come in every year. So there's a little bit of leeway in there. For guys, though, black males, I start at 40, trying to convince them to do their prostate screenings. Expecting by maybe 45, I get them in and we do an exam, and then we start doing them every year. Why do we do that? For some reason, black males get prostate cancers that are much more aggressive. They're working on it, but no one knows why that's the case. The people that will support not doing prostate exams and PSAs are the people that are looking at, there are several guys that have died with prostate cancer and never knew it, okay? Didn't have symptoms, right? And didn't have any inclination that something was wrong. So someone that says you don't need to test are the people that are looking at those scenarios. What I see in my clinic are the black males that come in with the cancers that are taken out within 2 days or 3 days. And so that drives me to start checking much earlier. Okay. So those are my experiences with cancer and my motivation to get folks in earlier, because I don't want to go through that either. You think that maybe your doctor doesn't go through those emotions, but sometimes we do. Could I have convinced this guy to come in earlier? And is it my fault that we didn't do? I didn't work harder to try to get him screened. Those kind of things. Okay, now he's been diagnosed, and now I gotta go find someone to see him. If he doesn't have insurance, calling the oncologist to see this guy is going to be real difficult. What kinds of insurance does he have if he doesn't have any? Because everything is going to cost. The visit's going to cost. The treatment's going to cost. The cancer, usually women, but the girls that follow you for your cancer treatments and keep you on schedule, that's a cost. Everything is a cost. And so we have some people that say, I don't have insurance, I'm just not going to go through it. And unfortunately, they don't. And we shouldn't have to have those scenarios. We should be able to provide the care that patients need. So it is a struggle. Everyone's working on it. I've been on several different committees and part of the groups that have encouraged making these things available, such as Every Woman Matters. I mean, that's a big thing to get a woman. I can check her cholesterol, we check blood sugars, do the mammogram, colonoscopy covered. All those things covered. That's a lot of things, a lot of problems or issues that if we did not do those, for some of those that are talking dollars and cents, they cost a lot of money. A diabetic, if we don't find diabetes, well, then they have diabetes, high blood pressure, high cholesterol, and I've got them on probably 4 medications. If you paid cash for those 4 medications, you might pay $200 a month easily on those 4 different medications. But we have people that say it's not worth to prevent those. It's not worth it to save money on doing all these screenings. But actually, we're paying a lot more money on the other end, taking care of all those problems. Same with cancer. And so if we can get them in early, get all those treatments in early, now we're dealing with a scenario that we can work with. When they come in and they show up and they don't have insurance and the guy has lung cancer, which has happened, and I send them off all these guys, we're paying a lot of money for that end stage health care. So my thing as a family practice doctor is obviously trying to get things found early, whatever the case may be. It's cancer, diabetes, because in the long run our goal is to make people healthy and keep people healthy. And so when it comes to insurance, for me, it's how can this guy afford all these things? So we have to go through the scenarios that we can to find ways to get those things paid for.
Well, I think we're probably ready for questions from the audience. Are there any questions or comments from the audience?
I'm aware of 4 screenings that you all have mentioned here, I think. The prostate one, the colon cancer, the breast cancer, and the uterine cancer. Are there any other basic screenings that people should know about? Those are the only ones I can think of.
Well, as far as cancer is concerned,
Right.
those are the four big ones. We don't do even lung cancer. Technically, there's not a screening test for lung cancer. When we test for, if we're concerned about cancer, we're going to do a chest X-ray. We go through their smoking history. If they've ever smoked, we actually check their aorta at times, to see if their aorta is big. So males that are over 55 and they've ever smoked, we don't talk about that one as much. If they've ever smoked and they're over 55, they actually need to be checked for aortic aneurysms. So that one doesn't get the publicity, but we still have, that's another screening test that we do. Those are the major ones. So
A follow-up question is, are there funds out there for people who've been diagnosed? I remember working in this whole breast cancer arena at one time and was told that this was Hispanic women didn't come in for the screenings because if they were, if they were screened and breast cancer was found, first of all, it was a cultural thing that their husbands didn't understand and wouldn't support. This was in western Nebraska, by the way. And in addition to that, they didn't have money for treatment, so why should they go get screened? At one point, I know that there were screening funds for treatment for those who weren't able to afford.
I personally, I don't know of those, so
I don't know if they're still
I'd
out
have to
there
do
or
some
not.
research on that. But
I can answer partially on that question. Every Woman Matters still exists, I do believe. It's been a few years since I've been out in the field educating Hispanics or Latinas, African American, Native Indian, the Asian. So I've been out in the Lincoln community, making the program very aware to all these nationalities. And with the Latino population, they did have a tendency to be a little more hush-hush about it. But the big issue there, again, is, and it's what we're doing today, and that's education. And so I would go out and I would go to the Hispanic Center and we would have these educational settings, and they could bring their husbands with if they cared to, but we would sit down and talk about breast cancer and the consequences if, it should come about. But the fact that the Every Woman Matters would pay for any woman over the age of 40 or with very little insurance, that opened a lot of doors, I think, for many of these ladies. And the fact, too, then it got to the point where we could actually cover down on the treatment expenses, which, oh my gosh, so thankful to know that they did that. Didn't know so much about it at the time I was educated, but after getting my own personal, like you said, medical bills, it's like, oh my gosh. And of course, although you're paying for insurance, you still have to pay a portion of that. And you're still thinking, oh, I better go get a third job. So Every Woman Matters is a program that we should be very grateful for being around to cover the mammograms, the cervical, the cholesterol, and all of that. And I do hope that someday that there will be such a program for the men. So...
Marcia, if I could say a word here, I think, one of the programs that the Community Health Endowment has funded has been a breast cancer outreach program. And We have a liaison that works in the community along with El Centro de las Americas. And the purpose of the breast cancer outreach program is to make sure that women are aware of, make sure they get preventative services and mammograms, et cetera, et cetera. And also, once that diagnosis is made, is not to let them just be there, but to find the resources in the community to make that happen. Now, I'm not the boss, not the boss, I'm the boss, but I'm not the expert. I supervise the woman who does this program, and I'm not all familiar with all the resources that are available in the community, but I know that Lori would be able to help us in that area. She's part of the Lincoln Breast Cancer Coalition, and I'm sure there's others in here who know what's available for women that don't have the resources to get health care, to basic health care. So I know they're not on the panel, but they might be able to help others in our community know what's available. And I see this as education for everybody.
I'll make one comment, and then I know we have a couple experts out in the field, but another part of the breast cancer outreach program that CHE supports is helping providers become more culturally competent so that there's more understanding about the cultural barriers that might prevent women or patients from different cultural backgrounds in getting treatment. So, and now I think Joan has a comment.
Well, there's a couple of things that, again, I'm kind of like Larry. I'm not the expert, but I know who is. There are probably 40 what they call compassionate care Medicaid options. Like, we all know that you can't get on Medicaid as an adult unless you're blind or disabled. But if you've been diagnosed with renal cancer, thyroid cancer, breast cancer, there's a whole list of them. And you can actually, if you qualify financial-wise, you can get on Medicaid compassionate care for treatment of that particular, if you're documented. If we have undocumented individuals, in Lincoln, CHE has funded a program that we can help anyone without insurance get access to care. So in Lincoln, we're covered on both sides, but throughout the state, many people don't know about the compassionate care for Medicaid. And then I have another question for, you have somebody that goes, okay. Dr. Anderson, you've been in Lincoln and Omaha and know, in my opinion, we have great providers in both areas. Frequently, I will be asked by families, especially when it's not maybe like Tracy's, a very good outcome projected. Should I go to the Cancer Centers of America? Should I go to Mayo? Should I go here? Should I go there? And my response is always talk to your oncologist about it, because I've never had anybody hesitate referring there, but sometimes it's a huge expense to the family to make those trips, and they're searching for answers because they don't like the answers they're getting. So I guess I'd just like to have your feeling on that, and maybe what your other colleagues would comment on that.
I mean, locally, we have several different cancer treatment centers that are capable of handling most of those things. Even in the scenario that of my best friend, she's got terminal cancer and she's being treated at UNMC. Only if nothing were to help would the doctor, the oncologist, would he consider sending her somewhere else? And so we have to get them into those treatment centers, but we have adequate care and professionals that could manage those right here in Omaha or Lincoln. So,
Lori, did you want to provide your perspective?
I'm Lori Vidlac. I help coordinate the Breast Cancer Control Partnership Network across the state. And the Lincoln program, as Larry said, was really fortunate, the Lincoln Breast Cancer Coalition, to receive this grant through CHE. And the beauty, the Lincoln really is the only community that has a breast cancer coalition. And the goal of the coalition is to make the connection between the partners. We have both hospitals involved. We have a variety of medical facilities, as well as the multicultural centers are involved. And the whole idea is to strengthen the connections between providers and outreach folks so that when they're are opportunities to educate women. The proper education is provided, and then if a diagnosis does occur, then the women can be connected with the kinds of services that they need to allow them to pay for it, to get the treatment that they need. I would just like to say that we're just next week we're having a meeting of the coalition, and we're receiving a research report that was done by some UNMC researchers who did some focus groups with Latina women, with women of lower incomes, and with African American women over the last several months, and is giving us a report on what they heard those women say were the barriers for them to move forward on either getting screened or, taking positive action. What we really want to do is promote getting early screening or getting screening so that you catch it early. But there's a lot of reasons why women don't do that. And so we're going to be hearing a report on that. But they also did interviews with providers in Lincoln to get some sense of, what do we need to do to strengthen those connections between women? What do we need to do to encourage women to become partners with their providers, to ask about risk assessment? Am I at an average risk or am I at an increased risk? And if I'm at an increased risk, what does that mean for me in terms of screening? Should I have more than what is recommended for an average risk woman, or more frequent kinds of tests? So anyway, we'll be getting that information. So if anyone is interested in being involved in that project as it moves forward, because once we get the research data, then we're going to really figure out how to make things work, let me know. I'll be happy. Give me your card. I'll give you mine, and we'll connect, and we'll keep you in the loop.
So one comment to piggyback that is the family history is an important part of your medical record. Unfortunately, though, in some cultures and some communities, even in my own, we don't know the histories. And so sometimes we aren't told. I don't know who has cancer in my family. I only know that my grandmother had diabetes and some other things because I was in medical school at the time, and so they felt like I was the family doctor, so they would tell me things. But as far as all of his other brothers and sisters that died of something, I don't know. So that's a limitation in assessing that risk, because that's an important part. If you have a sister or an aunt or grandmother with breast cancer, does that increase your risk? Yes, it does. Do we always know that information? No, we don't. A history of any kind of cancer in your immediate family increases your risk. So your grandparents, your aunts, your uncles, if they had colon cancer, does that increase your risk for breast cancer? Technically, yeah, it does, because now you might have inherited some genes that are predisposed to become cancerous. And so we, as physicians, we need to ask more questions about that. We do have ways to get more of that information when we're documenting, per se, our electronic medical records. So that's a big thing that, the government has said that all of our offices have to have an electronic medical records. Why? Well, there are some flags in there that will help you. Did you ask about cancer? Did you ask about smoking? Did you ask about, the last time they went to their eye doctor if they're diabetic? And so all of those things are trying to help us get a better picture of your health based on someone else's health in your family. If you don't know that, you really don't know your own health history.
And can I add something to that? Because you're looking at it at a physician's point of view, but as a patient speaking to the doctor too, not only are they going to analyze the familial background, but they're also going to look at you as an individual. I know when I had my surgeon and I were speaking, and we were talking about the treatment process and what would be the best option. And of course, the first thing in my head, and I said it out loud, is I want a total mastectomy. And she just wait. I said, no, I want a total mastectomy. Just, no, we need to talk about this. And so she gave her little spill, and I was like, okay, now I'm going to tell you something. I am a single mom with a 14-year-old son. Now I want you to analyze that, and then I want you to tell me if you're going to come up with that same answer. She came up with the same answer. So we went ahead and did that partial mastectomy, and it's important to know that when people hear about different stories, because it was a few months later, a friend contacted me and she said, "Oh, I have a friend who's going through the same thing you did, and she's having a total mastectomy and going through all these different treatment procedures." I'm thinking, stop, because it upset me for one thing, because I wanted one thing and I didn't really get it, although it was in the best, it was best for me. So we have to think about too, when a physician's going to sit down with their patient, they're going to assess what's necessary for that individual, not what's best for a group of folks. Because I had also, during the assessment after the surgery and whatnot, I was quoted, because I did have a few lymph nodes removed. The sentinel node, which is basically your mother node here in the axilla armpit area, is, a fairly big lymph node, and unfortunately that one was cancerous. The other couple after that was not. But because there was only a 3 removal, there really wasn't an issue about lymphedema. Well, about a month into the chemo, what happens? All of a sudden, my hand gets real big, and it's going up my arm, and you're talking about freaking. That freaked me out. The cancer wasn't even a concern, but that freaked me out. So I went in, did an ultrasound and all that, and yes, it was lymphedema, and so that I definitely will have to live with for the rest of my time. But it's important to know that as a patient, you're going to talk to that physician again, and you're going to discuss your situation, not everyone else's.
And a lot of that comes back to your primary care doctors. The oncologists, they do the seizures, do the treatments, and then typically we get the comments about, what about the diarrhea after a prostate? Some prostate cancer surgeries can cause some diarrhea, they can cause erectional dysfunction, and so that comes back to us to discuss. And sometimes what I try to do is try to prep them up too, with as much as I know about some of those possible side effects and scenarios, so such as the lymphedema. I mean, my mother-in-law has the same thing. Did it develop right away? No, it was probably 20 years after her surgery that she started to develop. She kept saying, why is my arm getting so puffy? And so we had to talk to her about that was one of the side effects of scenarios, but it didn't happen right away. It was late after her breast cancer surgery. And she had bilateral mastectomies, and so I was able to talk to her about it. But you can't change anything. But her oncologist is long gone as far as who does she call about your surgery that you had 25 years ago. She has to talk to her primary care doctor, just like you guys have to build that relationship, and so that someone can answer those kind of questions. It's not always going to be your oncologist. It's going to come back to your primary care doctor.
There seems to be a consistent connection to heredity and genetics as far as cancer. But you also have alluded to, and I know from personal growing up, that men of color have a lacking in following up on their health care, which is sociological. That's not genetics, that's not innate. So has the medical field, for one, I'm sitting here thinking in 2 arenas. One, education. I'm going to check to see if that's part of the curriculum in our classes, health classes, which is a requirement. But then I'm thinking also, in another hat, as president of Malone Center Board, if there's a way that we can, and other agencies, El Centro, in their programming, that they could include that to undo or unpack some of that socialization for especially young males, because, if we start early and helping them to understand the importance of that, maybe we can counter some of that male ego or whatever it is.
There are cultural sensitivity classes that you take, and they try to cover all the bases. For me, asking me that question, I'm really frustrated that our country, our culture is so diverse. Yet when I was here in Lincoln, there was 3 African American male doctors. One was a pathologist who you never seen, and one was a neonatologist who worked at the hospital. And so it was me. And although I enjoy doing this stuff, I really do, it gets overwhelming, because then I feel like, well, if I don't get out there and I don't speak to these guys and I'm not pushing them to go see a doctor, which when I was here, I was the doctor, then they don't go. And so when I see my kids in my clinics, I'm pushing them all the time. We need more doctors. We need more doctors. We need more lawyers. Why shouldn't the treatment team reflect the population? And until that really happens, you're gonna. When I first started in Lincoln, I had guys that came to me that hadn't seen doctors in 25 years. Why? Because there hadn't been a black doctor in Lincoln for 25 years, and so they just didn't go. They weren't going to go to the black doctor or go to a white doctor. And so I was here, and so you feel that pressure of, I've got to help, get these guys in. And until doctors of any color get out of their offices and do community talks and interact with the community, people aren't getting exposed to those kind of discussions. They don't really know how important it is to show up for things like this and show up for your appointments. And it seems like all these guys they're healthy. They're not. There's cholesterol that is killing people with heart attacks, and they're not being treated. And the discussion is, they're not all these treatments. They're not always medicine. Diet, exercise, getting out there and being active can control a lot of these things. And they're not encouraged to do that, right? Until some of the doctors get out, like I said, and mention these things. We got to encourage people to take care of themselves. It's not that you come to the doctor for him or her to take care of you. It's up to us to educate you to take care of yourself. And if they're not getting that message, then they don't come in.
I think that's one of the reasons I do what I do, or I've done what I've done. This is probably the 3rd time that I know it's the 2nd for sure, maybe the 3rd time that I've talked about my experience with cancer, just because, first of all, I'm male, and I'm also a black male, and we don't talk about those kind of things to begin with. We really don't, especially something that deals with, quote, your malehood, maleness, and so forth and so on. And I'll continue to do it as long as I can, because I think, again, as I said, the only reason I'm here is I think that I had early detection, because it was growing. There's no ifs, ands, or buts about it. And like the doctor told me, by the time you would have known something was wrong, it would have been too late. So, but I think Thomas mentioned something that I think, I hadn't even thought about, and that is doing some sort of outreach to our young African American men, and indicating to them the importance of preventative care. That's not happening. That's not happening. And that might be a future community health endowment proposal, as I sit here thinking about it. But I think that's something to think about. And not just African American men, men of color, period. This is something that just isn't talked about. And
I wanted to kind of address what Thomas Christie was saying, and I can remember when Dr. Anderson was living down here, and Dr. Anderson has been a friend for many years, and I can't even remember when I first met him, because when we first met, then we just started doing outreach and working together. But I can remember two things I wanted to talk about, but one was I can remember when Carol Mitchell worked at the health department, and we decided, Carol Mitchell and Dr. Anderson and myself, and we decided we needed to do something, some type of outreach for, at that time, African American males or men of color, and we decided to do something over at the Salvation Army. And we had said that we were only going to do it from 6 to 8 that evening, but we had publicized it, and Dr. Anderson and I hadn't talked to Dr. Anderson about if I could publicize, could these men talk to the doctor? And so some people from the health department, I think, done cholesterols and blood pressures, and we had put a little booklet together with some awareness tips for guys, and even down to what your cholesterol should be and what your normal blood pressure should be. And then you could come and talk to the doctor about whatever concern you had, whatever health concern you had. And I think that night we stayed there till 10:30 because we had so many males, African-American males from the community that came, and they took advantage of the lightweight health screenings, and then they wanted to talk to the doctor. And they did. They talked to Dr. Anderson, and some of them talked openly, and those that wanted to talk in private got to go in a little corner and talk to Dr. Anderson about some specific private things that were going on in their life. And from that result, some began to see Dr. Anderson as a patient, some Dr. Anderson seen at no cost, some we were able to refer somewhere else where they could be seen at no charge. But that was really huge, and I think for months after that, these folks were contacting us, and we were kind of referring them to different places for some type of health care. But that was huge for us, but we weren't able to do it again. But we stayed there hours on top of hours afterwards. And so I wanted to just say that. And I'm always, Dr. Anderson, as you all know, he's housed in Omaha, but my husband is a patient of his. And I appreciate, Larry, you always giving your story and talking about your story, because Dr. Anderson would tell you, I take him up there. I make the appointment. I take him up there. Then I go in the room and say, will you check this? Will you check that? Do this, do that, do this. Then I go out in the waiting room, and I sit out in the waiting room for I don't know how long while Dr. Anderson does all these things. And then I come back in, and then we discuss them, because I want to make sure that he has a thorough understanding of everything that's going on and what needs to take place. Now, because of this health war going on, and Dr. Anderson, where he's at and what's going on with Blue Cross and Blue Shield, at first I got ready to panic because I'm like, oh my God, he needs to find another doctor. But then on the other hand, I was like, no, he doesn't. Because if we have to pay a few extra dollars to stay where we're at, then that's what we have to do, because we're comfortable where we're at, and we know what kind of care we're going to get. So we're good with that. And then the other thing that I wanted to say really quick, when we were talking about genetics, and I think, Joan, you were asking Dr. Anderson the question about folks being referred to the Cancer Centers of America or Mayo Clinic and that type of thing. Over the last 18 months, I've been going through some health concerns in that arena, and I've had like 4 tumors removed off the back of my neck in the same place, and one off my wrist that keeps popping up. And so then the question came up, maybe we need to send you to Mayo Clinic and have Mayo Clinic look at you. But then my doctor said, no, we have some doctors right around here that have came from Mayo Clinic that are housed right here. And we're going to start with some genetic testing. And to what you were talking about, Tracy and Dr. Anderson, how you said how important it is that we know our family history. Well, my first appointment with that doctor for an hour and a half was to come up with my family history, to know what was going on and who has what and that type of thing. And now my appointments to go back now are for some genetic testing, the same thing that they would have done up at Mayo Clinic. And I'm getting that same type of care right here. So I just wanted to say that. So.
Talking about the genetics is interesting to me. I'm the youngest of 3 children, and I've already lost my brother and my sister, so they're gone, and I've already outlived them. And I try to think, what's different about my life from theirs? And all I can say, you've mentioned smoking, and that's the only thing that I've never done. And they weren't excessive smokers, but were occasional ones at one time. Can it really make that much difference?
Sure. It affects you in lots of different ways. I mean, even just your quality of life can be affected. We've had patients lived 100 and they didn't get lung cancer, but they couldn't go 3 steps without sucking down some oxygen. And so does it make a difference? Yes, it does. It really does. not everything is genetic, of course. It's like you said, it's environmental and it's how you live your life. But there are some obvious things that are definite factors. So if you smoke, I try to work on people smoking, keep them from smoking. That's one thing they can do. Exercise, 10 minutes, 3 times a day, 3, 4, 5 times a week gets your numbers of exercise in. People will say, we live in Nebraska and it gets cold in the wintertime, I can't go outside and walk. I say, go to the mall, don't take any money, window shop. You can walk around for half an hour at the mall and get your 30 minutes in. So there's really, I can combat a lot of those excuses about that. We have several different things that we can use to help a person that's smoking. It's mental, it's physical, it's mechanical, but we have ways to address all 3 of those things.
Are there any other questions?
This one here.
I just wanted to ask both Larry and Tracy. I heard both of you talk about going through things when you at initial diagnosis, beyond the spending the money, that emotional piece. And I'm wondering if we have sufficient emotional supports for people when they get the diagnosis, following the diagnosis, and post-treatment, to see that you folks both seem to be doing really, really well, but I'm hoping that we have sufficient infrastructure to provide some of that emotional support for people, or if everybody just needs to rely on family.
I know, I went through Bryan Hospital, and I know Bryan and Life Point, which is an affiliate of Bryan Hospital, they have excellent resources. Personally, I did not take them. I felt I was strong enough of an individual to get through that. And I also worked there at one time. And so it was, for me personally, it was like, what are you going to tell me that I can already tell myself? Because if I was here, I'd be teaching the same course. So for me, I did not. But for others who may feel that they're not that strong of an individual, who do not have the family and the friends, that kind of a support, there are these resources out there, and I would suggest taking them.
That's a tough one. Again, not having a partner or a significant other in my life, and then, again, being a caregiver, it was doubly hard. It was hard. I cried a lot. I had friends, that would try to comfort me, but it was, this was a time that, I missed my mom. I was mama's boy, and mama was gone, and I didn't have nobody to talk to. I'd call my cousins and call my friends, but it was tough. And I did join a support group. There is a prostate support group that meets at Bryan LGH. I was the youngest guy. Yeah, and I'm no spring chicken. And I was the only person of color, too. And that just says something, once again, about the difficulties that we have in the African American or person of color community when it comes to talking about these issues and sharing about. That support group did help, but there wasn't anybody else like me there. But I dealt with that. I got over it. I got what I needed from that group. I think it goes back to what Thomas Christie said, the notion about, I wish more African American men, and I know some in the community, would talk about their experiences, their health experiences. It just doesn't happen, but it was tough. I cried a lot. I isolated. I would go to work with a happy face, but I was dying inside. And but I got through it. I lost my faith, too, which is an important part of it. I thought, I was angry. I didn't deserve this, and I don't want to turn this into a revival or religious meeting. But I was disappointed. I didn't deserve this. But I dealt with all that. But those were some of the emotions that I went through. And I thought, well, what's going to happen to my sister, Rita? What if, what are we going to do? It was tough, but I worked through it. I almost went to a therapist to get through this, okay? But with friends and a dear cousin, I got through it. But to say that I swim through this like a soldier or a trooper, no, that didn't happen. That did not happen at all. I'm thankful I don't drink, but I was darn close to it again. It was pushing me that close to the borderline, but I knew that drinking wasn't going to make anything more better. I knew that. After my dad died, I went out and tied one on. He was still dead afterwards. He was still dead afterwards. He did not raise from the dead. And I just made life miserable for everyone around me afterwards. So I knew that wasn't the answer, but emotionally, it was tough. Okay. I didn't just have that close family that I could rely on.
Yeah. To add to that, I don't work directly for the hospitals or anything, but one of the big trends in all of these cancer centers are nurse navigators. And so, I've personally made a phone call to the nurse navigator, and she's like, name, date of birth, we'll take it from here. And then they help manage, where do you need to go, who's next, what do you need to do, where do you need to be. So there are resources out there that she's going to be your nurse navigator. And so the things that you need, she becomes your resource to get those things done. And so I know for sure that, the centers in Omaha have them. I'm pretty sure that St. Elizabeth's has them. I would assume that Bryan has them too, because this is such, like you said, you got to go through all these emotions. If you don't have that family support, who do you lean on? And so this has become their little niche, is to be that person. They might not be personally your person, but they can, the resources, and get you to the people you need. If you need a psychiatrist, would that be uncommon that someone recently diagnosed with cancer would need a psychiatrist? No, it's not uncommon. So they would be that resource to get you there. And so I've had good experiences with the nurse navigators for the patients that I've had to send to those centers.
I think we've got 2 more questions or comments, and then Lori will wrap it up.
Well, you're absolutely right. They do have nurse navigators, but in addition to that, because a lot of times that's focused at the early end when they're in the hospital, both oncology groups in Lincoln, and I'm sure in Omaha, they both have a social worker. If the patient makes their needs known, the social workers can actually try to identify someone. Like if they knew someone that was going through what Larry did, Larry, would you mind talking to this guy? So there are resources, but sometimes it's the patient somebody has to let you know.
I think there's a piece that came out in both Larry and Tracy's, especially Tracy's, and that is your employment. How important it is to have an understanding support system in who you work for. Larry didn't say this, but I know he believes it. His employer, Malone Center, was very supportive and flexibility and so forth. And so that's really critical that you would have that, because I know not all employers are going to be that supportive. And I'm sure Dr. Anderson has experienced that with his.
My best friend, she was in that situation. Her employer pretty much said, well, if you're not going to be able to work, we can't keep you employed. And so then she has to go back through the process of applying for Medicaid and grants or whatever to help her get things paid for. Because you're going to see all these chemos, and we're sorry that you have cancer, but we just can't keep you here. She didn't work for a big group that would be able to compensate for something like that.
Well, thank you very much. I'm going to put you all on the spot really quick, as if we haven't already. But I want you all, there's going to be people that are going to see this on TV, and as well as for the folks in the room. I know people watch it because people say they see me standing here talking. And so I'd like you all to just in one sentence tell the community something that you believe they should know, whether about cancer in this community, whether it be about their getting checked, whether it be about how they take care of a loved one, whatever it might be. But look at the group, look in the camera that's going to be where you're going to be seen on television, and tell the community something that you believe is important for them to know in just one sentence.
I would say those of you who are cancer survivors or dealing with cancer, share your stories. I think it's important that we let everyone know what it's like, how you feel, what you're going through, and the resources that you've accessed so that others can be helped.
Perfect. Tracy?
Be proactive. It is a journey. Use it to your advantage. It's educational. Take that into the community, to your loved ones. It guides them, it provides them the additional support.
Perfect.
Early prevention is best, so make sure you see your regular doctor for your routine screenings.
Perfect. Thank you so much. I know this community conversation really pointed to what we hope to accomplish here, and that was to have a conversation about important topics, but also to work towards some things we can do about it. And I think that I've heard some of those things happening here. I think I hear maybe a couple of grant applications coming on. But I think that's perfect. We've identified some things we need to do as a community, and we stand ready to work with all of you to make that happen. So as always, I am inspired and touched and grateful that you all would share your personal stories with us, and as well as you as a physician and your personal story with your best friend and going through that experience as well. So help me thank them for being here. That concludes our community conversation series, but as I mentioned to you, if you have ideas for how we can continue this with other topics as we've done this summer, we would be grateful for those ideas, and we'd encourage you to talk to us about that. And thank you all for being here very much.